This episode is sponsored by Dr. Chrono by EverHealth, the #1 mobile all-in-one EHR. Built specifically for medical practices, Dr. Chrono includes an integrated feature that powers a seamless payments acceptance experience. Dr. Chrono Payments offers multiple ways for patients to pay as well as insurance credit card processing. As a Dr. Chrono customer, you can easily activate our fully integrated payment solution that will streamline your cash flow and help you get paid anytime from anywhere. Deliver the best patient experience with a fast and easy way to collect payments. Visit drchrono.com/payments. That's drchrono.com/payments to learn more about Dr. Chrono today. Is there a DPC clinician, tech vendor, or industry champion that goes above and beyond to further elevate the DPC movement? Nominate them for a DPC Innovation Award to recognize them for creating traction, embracing innovation, and demonstrating commitment to the movement. DPC Innovation Award winners will be announced and honored at this year's Hint Summit, taking place in Denver, Colorado, September 27th through 28th. Nominate a DPC innovator at summit.hint.com, plus get $50 off your Hint Summit 2024 registration with promo code MyDPCStory. Direct primary care is an innovative, alternative path to insurance-driven healthcare. Typically, a patient pays their doctor a low monthly membership and, in return, builds a lasting relationship with their doctor and has their doctor available at their fingertips. Welcome to the My DPC Story podcast, where each week you will hear the ever-so-relatable stories shared by physicians who have chosen to practice medicine in their individual communities through the direct primary care model. I'm your host, Marielle Concepcion, family physician, DPC owner, and former fee-for-service doctor. I hope you enjoy today's episode and come away feeling inspired about the future of patient care, direct primary care.
Direct primary care to me has been a lifesaver. It's a way to practice medicine that is all about the patient and the physician. There's no interference from insurance companies, hospitals, pharmaceuticals. I love practicing like this because this is my calling, is to help people individually, getting to know the patients really well, having the time to talk to them, to research things, to educate myself again. So it's just good old flavor medicine with the technology that we can now use. So to me, it's the way medicine should be. I am Belen Amat, owner of Direct Primary Care of West Michigan in Grand Rapids, Michigan. And this is my DPC story.
Dr. Belen Amat was born and raised in Mexico City, where she studied medicine at the Universidad Panamericana and graduated with honors. She decided to pursue a dual specialty in internal medicine and pediatrics at GRMEP in Grand Rapids, Michigan, where she found wonderful people and a great city for her family. Ever since she was a child, she wanted to be a doctor and help people, especially when they were sick and needed help the most. She put her lifelong love of science to work, figuring out complex medical issues and preventing illnesses. After several years of working in large clinics and hospital networks such as Spectrum Health and St. Mary's, she decided to start her own practice with the idea of reviving the personalized attention she believes is the basis of a quality medical service. Her research into the direct primary care model showed high rates of patient satisfaction and improved medical and wellness outcomes through increased patient access and communication, so she decided to adopt this preventative model of care. Dr. Amat believes in patient care that is based on a personal relationship between a doctor and a patient, a relationship based in trust and communication. She volunteers for medical mission trips to Honduras and offers service in Spanish for the Spanish-speaking community. Dr. Amat is board certified in internal medicine and pediatrics. She is a board member of the Michigan State Medical Society and president of Kent County Medical Society and also a member of the American College of Physicians. She opened Direct Primary Care of West Michigan in July of 2017. Welcome to the podcast, Dr. Amat.
Thank you for inviting me.
Belen, it is so wonderful to talk with you today because prior to this interview, Dr. Clodagh Ryan had pointed out that you have run a successful DPC since 2017, and you every day in your practice are proving that DPC is not built for only the people who have more than enough means to pay for this access to quality care. So with that said, I want to take a step back to your training. When you were training in medical school, you had a fifth year requirement to go out into the community and serve in a rural area. Can you tell us about that experience and how has that impacted you and your practice every day?
Yes, so medical school in Mexico is 6 years. So you do 2 years of basic science, then you do 2 years of rotations, just regular rotations, and then 1 year of internship. So you pretty much you're in charge of the patients in the hospital for a whole year, and then you do a rural service. So you're actually done with medical school, but they will not give you a license until you do this year rural service. So you go out, in my case, because I was in a private university, we got to choose where to go. Based on our grades, we could choose where to go. And so that was good because as much as I wanted the rural experience, I did not want to go to that place where they drop you in a helicopter and see you later and you're it. So where I went was about 3 hours away from Mexico City in the mountains. I was a little scared to go because I am a city girl. I grew up in Mexico City, which is like 25 million people. And we have all the services and it's all fancy and I travel all my life. So I had never lived in this kind of environment. So when it got time to go, it's super fun because the town will give you the clinic. In most places you live in the clinic. In the town I was in, we actually had a house. The town provided this house for us. And so if they didn't have power, I didn't have power. If they didn't have water, I didn't have water. And we had water once a week. So our house had like a collecting system. So we could fill it up. And for 1 week, we had that water. But if for some reason there was no power, then there was no water. So sometimes we didn't have water for a couple of weeks, which is pretty interesting. You can live with almost anything except water. The water power, who cares? And we didn't have cable. It was just awesome. One of my favorite things to do, and this is obviously nothing to do with medicine, was to sit in my car and listen to the traffic report from Mexico City and just look at the mountains. It was just amazing. So for 1 year, you are the town's doctor and you are under the supervision of the government. A guy from the government who you meet is a public health person, not a doctor, but a public health person who you meet once a week. And you just report the numbers to them of what you've seen in the week. So diabetics, pregnant people, they keep really good control of the pregnant people, all their follow-up. And you do pretty much everything in the town. You are the town's doctor for a whole year. There were two of us, another med student and me, and we had 3,500 patients, let's say, that lived in this town. They're actually two towns, but they were so close together, the clinic was in the middle. So we actually had two towns. And that's what there were two of us. Usually you're by yourself, which is kind of scary sometimes up in the buildings with, no security. The interesting thing too is you become part of the town. But in Mexico, the doctor is like the doctor, right? Is the priest and the doctor. And whatever you say goes. So in that sense, it was a very rich experience because it takes you out of the comfort zone of you have all the supervision. And then you're in this place that's gorgeous, but you have very little resources. There's no lab. So you treat patients not knowing what their labs are. You take care of more complicated stuff that you would normally do where you would refer people out. There's no referral. You deliver babies, the closest city was a half hour away. And I would give the pregnant patients my cell phone, and they would call me anytime of day and night, and I would take them to the hospital to deliver the babies because I did not want that experience. That's why I'm med peace and not family. The main reason is I did not want the babies because the babies get stuck and you're it, and there's nothing you can. We didn't even have a rescue box with an ambo bag. That's how bare it was. By the end of that year, we spruced up the clinic and make it better. But still, you're so used to technology. And I mean, even in Mexico City, the hospitals are pretty fancy. And all of a sudden you're thrown into this. And now you're practicing on your own and you don't have any supervision. You can call your teachers from med school and ask questions, but it's not like real supervision where you could just say, hey, can you look at this with me? None of that.
When you're talking about resources like electricity and water, did you also have waxing and waning of resources that you needed to use in your clinic as well, like gloves?
Not so much because these clinics are stocked by the government. So they actually stocked our pharmacy. It was a little like DPC. So this is a funny thing because DPC feels a lot like that because we had a little pharmacy. And the government gives you their formulary. So you have amoxicillin and Bactrim, a few antibiotics, a few blood pressure meds, metformin, and that's it. You don't get anything fancy. Sometimes we would have missionary trips that would come through from the US, which I have certain opinions about those, but they would leave medications with us. So sometimes we did have some fancy stuff that we used, but most times it was just what the government would provide for us. Sure. And in general, like, we did have everything in this clinic. In medical school, some of the hospitals in Mexico don't have resources. So yes, you have to bring your own gloves or you're doing an exam without gloves. So I'm like, no, yeah, I'm bringing my own gloves. Thank you very much. So yeah, some of the public hospitals don't have resources and you just have to do your own. But the clinic was pretty well stocked. One of the benefits we had is it had a power, like a backup generator. So even if the town didn't have electricity, we had electricity in the clinic. So we could use the shower. If a kid came in with a fever, the first thing we would have, and there were nursing students, so it was awesome because the nursing students were also doing the rural service. And we would have the nurse, okay, get the kid in the shower and try to bring their temperature down before we see them. It was so nice, make the kid comfortable. So in that sense, and we could ask for stuff because this clinic I was in had a foundation from a religious group that was in town. So sometimes we could ask for things. We actually had a kid who was on peritoneal dialysis during our year. I know. So my student diagnosed this kid with renal failure. He came in full nephrotic syndrome. He was the whole thing, and she had no labs. And she diagnosed him. She said, this kid is renal failure. We were able to send him to Mexico City to get a catheter put in and the bags of solution. And here you go, do your dialysis. So their house, they were very poor, and their house had like dirt floor. And of course they had no power. And of course they had nothing else. So the mom would bring the kid to the clinic every day. And she learned how to do the bag exchange. And we had a microwave so she could, warm up the solution. And we did peritoneal dialysis for a whole year for this kid, and he ended up getting a transplant after that. But it was a really great experience because, of course, you see all the complications from doing dialysis without labs. So he once had seizures, and so they called us. Somebody came running. This is like you could make a movie out of this. This person came running because their house, you couldn't get to their house with a car. So they came running, and something's wrong. He's like not responding. So there I go, and I had a truck, like a big fancy truck with 4x4. So we drove as far as we could, and then we ran up the hill to get this kid out of his house. And yeah, he was in status epilepticus. So we grabbed him. I would never do this like in a normal situation, but he's gonna die. We put him in the back of the truck with the mom and my friend, and we drove him to the city, into the hospital, and ran into the hospital and just, here's this kid in the ER. He did fine, but oh my God, that was scary.
Absolutely.
So yeah, it was like, oh my God. But I don't think I had any like bad experiences. Sometimes things can happen where patients die and there's nothing you can do. I didn't have any of those experiences. I did hear from some of my classmates that maybe a baby would die in delivery, or maybe the town didn't like them. And then they will make your life miserable. So my experience was really good, and I loved it. It's a little bit like DPC because you really know the people, and because you're in the town where they are and what they're doing. Because you see when they're drunk. You see when they're like sleeping around. You see all these things that that as DPC too, because you become part of the community. which is the way it should be.
Even though, like you're saying, the doctor and the priest are at the top of the social pyramid or whatever you want to call it, you were still part of the community because you were there for a whole year living within those two villages. So that's incredible.
Mm-hmm.
When you had transitioned, you finished your year doing this internship and you made your way to Grand Rapids. You did your training. At what point did you learn about DPC?
So the first time I heard about DPC, I was already working. I was employed by a Catholic hospital that had an FQHC for Hispanic patients and also a homeless clinic. So I was working with them, loved working with them because that's what I wanted to do anyway. So I was just remembering because I just had this like flashback when I was looking at your podcast and who you'd interviewed, you talked to Garrison Bliss. And so my first contact with DPC was an article he wrote. And this was maybe a year or two into being employed, when I already knew that employed was not for me. The difficult thing was you get sucked in back into this whirlwind of being exploited. And I did not have time to think about breaking free until I think my mental health and my health in general was at stake, and my family and everything. But every few months, I would get back out again and try to look at, there wasn't a lot out. This is like, I graduated in 2011. Not a lot of DPCs were out there. So here and there, I would hear things. And eventually, I went to the first nuts and bolts. And that's how I jumped ship. I went to the conference, and by the end of that conference, actually, not even the end, we met first to socialize. And I actually went up to my room and called my husband. And I said, this is it. I'm jumping ship. And I got back from the conference, October, November. I quit in December. And 6 months later, I was opening. You have to work for 6 months as a penance after you quit. But that was how it was. So that was the first experience. But then that's how I kept looking for a way out, and then we get sucked back in. And it happens when you're employed is things get a little better. So you're okay. And then you boom again down, and then you're down in the dump for 6 months. And then all of a sudden you can breathe a little. And I think it's the way the system is designed to keep you in. Who wants to burn you out in the first year? It's let's tighten it a little bit and then let go a little bit and then tighten it and then a little bit. So you get used to it too. You're like, oh, it's not that bad anymore.
And the golden handcuffs of, oh, we'll give you the salary. And then after so many years, we're going to take that salary away because you are so deep into the system that you have to keep working because we've given you money potentially for your mortgage and you've already purchased a home here. And so it's really hard to pick up and leave.
You're so deprived when you're a resident. Maybe the difference in my experience to other physicians was I did not grow up here and I didn't have loans because I went to med school in Mexico. So then I didn't start my professional life with these horrible loans and all these restrictions. I was on a visa, so I did have some restrictions. I couldn't just go on my own. So I did have to wait for me to be able to not have a sponsor and work on my own. But I didn't have that mental, like you said, the golden cuffs of being stuck because now you have this mortgage. And we actually, and you probably know it, but what we did as a family is to plan to go to DPC is cut back on the lifestyle first, because the last thing you want is go on your own. And then you can't keep up because your bills are horrible, right? Your mortgage is terrible. Your loans are terrible. And then you want to keep up with this lifestyle with this income, that doesn't work. So
stay with us. We'll be right back. Thank you to Spruce Health for supporting the My DPC Story podcast. The ways we communicate have changed dramatically over the past decades, but technology and tools in healthcare have not kept pace. Patients want more access and digital convenience, as well as the ability to text their care teams. Care teams are inundated with more communication and rising expectations, but are still using tools and technology stuck in prior decades. Spruce Health created a solution for the tech-forward DPC practice by creating a communication product designed to serve both the patient and the doctor through intuitive HIPAA-compliant workflows, tagging, scheduled messages, and triage templates ready for use, whether you're on your phone or in the exam room. New users get 20% off for the first 12 months of a paid plan with code MARYAL20. That's MARYAL20. So check out Spruce Health today at sprucehealth.com or check out the link in the show notes. Definitely. When you mentioned visa, so I want to go back and ask, when you had transitioned from Mexico City and medical school and your internship, you were at St. Mary's, is that correct?
So first I was at St. Mary's, yes.
Yep.
When I finished residency, yeah.
Yep. So after residency, you had been employed for a bit. When you talk about that you had to have some sort of supervision until a certain point, with the visa in the picture, did you have to have any supervision after opening your DPC?
No. And with the visa, all that they do is it's just a sponsorship. So it's not like you have to have somebody watching over, make sure you don't kill patients. That's not that kind of supervision. It's more of, you have to work these hours. You can't work anywhere else. It's more like an extension of residency in a way. You work more hours than, people don't know this, but doctors that are on visas work more hours and get paid the same or less, because clinical hours are 32 hours per week. Most people get paid for 32. We have to work 40 for the visa. So you work 40 hours, 40 clinical hours, patient hours, on top of then doing your charts and all this other stuff. So those 40 hours are just of patient care. So you work more hours seeing patients, but you get paid the same or less. In my case, it was probably less because I was in a FQHC. So you don't get paid the same as the docs that are in the fancy neighborhoods, which is, to me, was like, that was one of the things I was able to fix. Right as I left that hospital, they changed the compensation of the physicians that worked in FQHC and homeless clinic. After me bugging them for years, and in every meeting, they finally changed it. So I feel that it was a little check mark of, I made it my contribution, at least, that the physicians that are left in the environment at least don't have to fight with that. It's one less thing.
Yeah, what a wonderful impact, a lasting impact that you left in your residency and in your community. So with that, I want to ask, when you decided to do DPC, when you had read Garrison's article, when you had gone to Nuts and Bolts, after you had called your husband, between when you quit in December and June, when you opened of 2017, what was going on in your mind in terms of, this is the DPC that I'm going to create? What were the goals that you had for yourself when you were about to open?
So you always have to, any business you make, you have to have an ideal picture of what it looks like. So in my book, and it's funny because it wasn't about the number of patients. It wasn't about the hours I would work. None of that. I'm not like that. So my goals are never like that. So in my mind, I wanted a place where the patients could just come in and sit down and have a cup of coffee with me. That was what I pictured. And then what I did is materialize that so it would look like my dream. So you know how when you have a dream and you see a house and it's so clear in your mind, but if somebody told you draw the house, you can't. But if you see it, you know it, right? If you recognize it, you're like, that's what it looks like. So that's how I found my space. After months and months, because I started looking at space from January, so I was still employed. I started looking at office space and I was like, ew, no, that does not look at all. It's like same setup, right? You come in, there's a waiting area with a little window thingy with the glass, which is so annoying. And then there's a person sitting there, which in my case, there wasn't going to be anybody. And then you have the hallway with the rooms on one side. And then the other side has the storage. And every medical facility is like that. So every space was like that. And I had to get the realtor to understand. She kept saying concierge, which just annoyed me. And I'm like, you need to understand, first of all, it's not concierge. And second of all, I need a space where it feels like this. And she couldn't get it. And then she, at some point, it switched in her head when I kept saying no to the spaces, which said, let's look at something completely different. Thank you. And so she took me to this office and I looked, and it was like in the winter. So the view wasn't the greatest. It was all gray. And I'm like, this is it. And I just knew it was. The same with the furniture, the same with every painting, and every little thing I put in the office. It just goes with that plan, that final plan. Now, organizing all this, did I know what I was going to do day to day? No, I had no clue. And I wasn't part of the DPC Facebook group at all because my no compete was very scary. And the hospital was like watching me. And they said, you cannot do anything online until this date. And so I was very careful. And maybe it was just paranoia on my side, but it was all in writing. So my lawyer was like, yeah, you probably should like lay low. So I didn't advertise. I didn't publish my website until exactly the date that is said on that now compete that I could open. So that actually I didn't really have a clear idea in my mind of how I was going to see patients and all these things. It was funny because my husband, he said, shouldn't you do like a dry run? Let's practice. So I'll pretend to be your patient. And I was like, I don't have to do that because I actually know how to do that. What I don't know is where to get supplies and, what do you buy? Furniture and an exam table. And, I didn't know you had to do the sharps thing. And then, to get a CLIA, to do CLIA wave tests. All these things that I found out more by chance or talking to other people. They'd be like, did you get this permit? I'm like, sure, I have it. Of course not. You find out that you're doing things kind of. So that is my learning point for people is do your research. But I did not have a clear idea of where I wanted to go. I just thought I would do what everybody else was doing, which is 600 patients. I think you asked me about the prices at some point. I didn't come up with the prices. I stole the prices that others were doing. Like if it works in Kansas, why can't it work in Grand Rapids? So the only thing I did is I didn't go as high as most people for the older people. So kids are 25 if they're by themselves, which I changed. So that's a big learning point. Kids, if they're by themselves, don't charge as a family because it's just like free care. If they're part of a family, then I do a discount for kids. So and I have large families that have 5 kids, 7 kids. And I think it's a great help to them if I don't charge gazillion to see the kids. So by being MedPeds, I can do that because I compensate with the adults. So my adults pay mostly 50, and that's my biggest panel is in the 50 range, and then 75 for people that are 52 and older. I don't have a ton of older people. I wish I had more, and I always thought about maybe it's the price, and it could be because the price kind of fits my people. So the 50 is a perfect price for them.
When you visualized your ideal patient opening the clinic versus your ideal patient now, has that changed?
Oh, totally. So one of my worries doing DPC, when I would see what people would say about DPC, was that I was going to just enter the word well, right? There's all these healthy people that really don't need me, but they want to just the reassurance that they're okay. And they take up all their time and energy. Their energy sucks. So I thought that was going to be my people. I thought that I'm giving up on the Hispanic community and all the people that can't afford this. But to me, there wasn't another choice. At this point, it was like I either do this or I quit medicine. So I had given up on that. I said, I'll compensate doing other things, but in my practice, I'm just going to be here. I was thinking of myself more of a concierge, like it would end up being more that kind of practice. Oh my God, was I surprised that was not the case. So that was a big surprise. And let me tell you how that happened, because it was very interesting. I went to the Chamber of Commerce. Everybody should go to the Chamber of Commerce. Honestly, that's how you get to meet people is first thing. Because I'm like, how do you meet other people and talk about DPC and how do you get patients? And I was not in that Facebook group to ask that. I did used to email Josh Humber and he would give me advice, but he wasn't here to see the town, to understand this town. So I went to the chamber and I made an appointment with the guy that did business development. Lo and behold, I knew him from before because he is also Hispanic. He's from Texas, but his family's from Mexico. And he knew me from before and the value of being in the same town, keeping the same town. We didn't know each other really well, but we'd seen each other at events. And when I explained to him what DPC was, he was like, that's amazing. Why isn't everybody doing this? And this would be a huge hit with the Hispanic community. And I was like, really? Oh, I didn't think of that. So what he did which is brilliant. He set up a press conference at the chamber in Spanish for the Spanish-speaking media. So then I had the newspapers and the radio that are for the Hispanic community. And then these guys interviewed me, guys, because there were no women really. And after that, I got invited to radio interviews. I did write for the newspaper for maybe a couple of years, where I would write a little column in their weekly newspaper about like colds and how do you do cancer screening and how to take over-the-counter medicines, and just very basic. And did some exchanges, right? I'll write your column, but you give me an ad. And we still do things like that. I still participate, even though I'm full. I still help them when they have an event. Or the radio, all through the first year of COVID, I did interviews every week to keep up with the information for the Hispanic community. So it's more than just where do I get patients, is how do I integrate myself into a community where I've been a stranger. I've been up in the castle seeing patients, not having to do anything with the community. Yeah, maybe you go to an event or two, but you're not ingrained in the culture. So that was the way I connected. And it was so eye-opening because I didn't even have brochures in Spanish. Okay, I had to emergently call my sister-in-law who did my brochures and say, I need them in Spanish, like stat, because we have this press conference next week. And so that's how I had no idea this was going to happen. And I was able to just say, oh, okay, let's do this. And a majority of my patients are Spanish speaking. I would say about 2/3 easily of my patients are Spanish speaking.
Stay with us. We'll be right back. Have you tried an AI scribe in your clinic? Well, I've tried so many, and I can say Heidi Health is the best AI scribe I have come across thus far. With Heidi Health, I can create unlimited customizable templates for my notes to help me truly cut down on the time I'm spending charting. Template for pediatric well child check? Done. Template for weight loss management? Done. Some of my favorite things I've built into my AI template, beyond the general soap note, are having a list of actionables for our team to take after a patient visit, having the diagnoses listed, and creating an after-visit summary for our patients. Not only have I found Heidi Health to be the most helpful, customizable AI scribe so far, it's also more affordable than most out there. So try Heidi Health today and see how you can harness the power of an AI scribe for your practice. To get an entire month of Heidi Pro free, go to the homepage of mydpcstory.com and click on the Heidi Health ad. Wonderful. And I go back to how you shared about your experience in your internship area. Like, you completely were a stranger to that community and you did the same thing there. You had to become part of your community to serve your community to the best of your ability. So that's wonderful. Now, let me ask, in terms of the patient population, you said 2/3 about are Spanish speaking. What about in terms of insurance? What types of insurance do people have?
Most, I would say, and I probably should redo the numbers because it's been a few months, but out of my Spanish speaking patients, I would say maybe 20% have insurance. The rest don't. I have a good solid number of undocumented patients that I actually know their real name, and I don't want to know what they're doing and how they work. I don't want to know, but they trust me because I speak Spanish and I understand the culture. And even though in Mexico, I'm not kind of part of their town, because in Mexico, I'm also separated socially because I had an education and my parents were from Spain. And so you're not like from there culturally in a lot of ways. They still are like, you speak Spanish, but you also understand our culture. You understand how we eat. You understand how we relate to each other. You understand the family, the church, all these things that make up our culture. I understand them. And it doesn't matter if somebody's from Peru. There's little variation. Like, oh, you eat this instead of that. But in the end, we are one culture with little variation if you go to different countries. So it's not just speaking Spanish, because a lot of them would say, yeah, I see this other doctor that speaks Spanish, but they're American. So then they're like, oh, it's gringo. So then they're like, they don't understand me. And you add the unrushed thing that they know. They're used to that because that's how they had seen the doctor in their country. So to them, it's like going back to how they used to. And in Mexico, and it probably happens in a lot of Latin America, people pay to see the doctor. So they're not against paying. And the $50 a month is like perfect pricing for them. A lot of people say, oh, you're undervaluing or whatever. It depends on your patient population. For my population, that's the perfect price. Now, do I have some rich people that love it because it's like so inexpensive to see me, right? Yeah, I have a few people like that you're like, okay, you could spend a little more, but I'm not going to treat them different. Maybe they're with me because they like the personal thing, or they like the fact that I'm not going to be bugging them for everything. Like, you have to come in for this. I'm not their mother. So I'm there if you need me, but I'm not going to like hound you. So yes, the majority of my Hispanic patients are not insured, which sometimes it's easier because then I don't have to do a prior auth. I don't have to worry about prescription coverage. I just treat them with generic medications. The challenge is if they need a specialist. That's a challenge. Most of them don't mind paying. Obviously, these are not patients that would be like in the Medicaid kind of range. People that can't even afford $50 a month. That's why there's Medicaid and there's these clinics, right? The FQHC where I used to work, where they do a sliding scale. That's a place for somebody that cannot afford 50. But most of the people I see are just a little tiny above that. They're factory workers, farm workers. I have a ton of like cow farmers, which is, I don't know, they talk to each other. It's very interesting to me because I don't know that here it works. So I always want to know, it's like, how do you do it? And what do you do? And what hours do you work? And what do you do when you're working? And I want to understand, what it is to go at 3 a.m. and get the cows out. We have a few inches of snow, maybe, or ice. And it's 3 a.m. and you have to get the cows out. Oh, goodness gracious. Yeah. So very interesting. I love learning about what people are doing in their lives.
These are the details that I feel that just in my short time in my own DPC clinic, I know my patients way better now, even the ones I've taken care of for over 6 years. I'm like, I didn't know that about you. Now that you are full, what is your maximum number that you are comfortable with in terms of number of patients? And how do you manage your wait list for people who are still interested in your practice but haven't yet joined?
So it's funny because I thought I would do 600. And then when you see how intense it is, I was like, I'm not sure I want to do 600. That sounds like a lot. And then you get to 100 and you're like, that's not too bad. And then you do 150 and 200 and you're like, it's not too bad. You kind of adjust, people settle in. It's so much work at the beginning. When people talk about that churn at the beginning, it's settled down. So it's 5 years in. I'm like, I'm good. I'm comfortable. I don't have as much churn. There's always people who move or people who all of a sudden change insurance and think that the grass is greener. We'll see you in 6 months when you experience that and then come back. So what I do, right now I'm like at between 300 and 350 is my happy number, I think, where I still have enough free time to do other things because I don't want to be seeing patients all day long, honestly, because I think the richer experience of being a physician is being able to do other things. You want to be a better person. So to be a better person, I have to have time to be with my family. I have to have time to do CME, not just force myself, but say, oh, I haven't read about this in a while. Or you see something interesting and a specialist suggests a diagnosis. Oh, I need to read up on that again. It never ends. You always have to study. And then other things that are not medical. Maybe I want time to read books, concept of reading that is not medical. Maybe I want time to go away for a vacation. Maybe I want time to explore different businesses. So once you settle in a comfy practice, then is when you can let your creativity go again and say, okay, I'm done running the churn of the building a practice and getting it to a decent size. What do I want to do next? So for me, I do have the syndrome of the shiny object a little bit, which it's not bad. I don't see it as a bad thing. The problem is if you just chase shiny objects and never do anything. Mm-hmm. But most of the shiny objects I've chased and pinned down have become really good things that I've been able to do. So I love the reading about different things and different businesses that I could do, some related to medicine, some not, and really doing those other things also for income. Because why not? Because I want to retire at some point. So some things are not money related, like participating in organized medicine, right? Being more involved in the King County Medical Society and the Michigan State Medical Society, and understanding how the sausage is made and how messy it is and how hard it is to change anything in the law and in medicine, and how everybody's got their interest and their hand in the bucket. So trying to get more involved in that, and also fighting for other physicians and for our patients. So to me, having time to go to those meetings, to do a legislative day and go talk to politicians, to me is so fun. So if they say, hey, next Wednesday, we need somebody to come talk about prior auth in Lansing to the legislators, I'm like, sign me up, clear my day, and I'm done. So having that freedom to say, I don't have, 15, 18, 20 patients in a day. And some DPCs do that. They do have the same schedule that they would have had it's more relaxed, but it's still pretty busy. I think being busy is so overrated. I don't want to be busy. I don't like being busy. I like having time to think. And I also enjoy life. And I also want to do other things. So I think 300 to 350 has been my good number. Could I take more? Maybe, but then I probably would have to hire staff. And I don't want to hire anybody right now. I'm good where I'm at. I have a nurse that works from home who used to work for me, not for me, but with me in the FQHC, and she is awesome. And I'm just waiting for her to be done having babies so she can work physically in the clinic. She knows it. It's like, come on, Jana, stop having babies. But she loves her family and everything. And so we are very flexible working with her. And she's so good as a nurse. She's just and so organized, which I'm not. And so she keeps me honest. She's like, oh, Dr. Amat, you need an eye wash station for it. And I'm like, you don't have to be safety cap. I'm like, who cares? Fine, I'll get it. So she keeps me on track to OSHA and the state and CLIA and all these things, and making sure I'm not breaking the law, which is good. She helps me with some of the stuff I don't like doing, requesting records and doing prior auths. I don't like that stuff. And I procrastinate and don't like doing it. So that's a good thing, to hire somebody to do the things you're not good at, but also the things you don't like doing. So if I don't mind taking care of the pharmacy, I don't mind doing the prescriptions myself. Some people hate doing the pharmacy side and want to hire somebody to do that. To me, I like that part. I like to do the pills and be involved in that. There are parts that I just like, oh, goodness gracious. Like, I guess some other things I could delegate to her, but I'm comfortable where I'm at, I think. I'm trying to explore some other things. Yeah.
As you've run your clinic since 2017 to now, have you toyed with hiring other people? And if so, how has that gone for you?
So I'm in and out in that idea. I'm like, I probably should have somebody who can draw blood, because I don't want to draw blood. I probably could do it, but I had to do it in Mexico when I was a student. So I probably could draw blood. Do I really want to do that? Not really. So it's one of those things where I'm back and forth. Right now, there's like nobody you can hire. So it's really hard to find somebody. I tried like at the end of last year, and then I'm like, no, I'm good. I don't need somebody. And then I, change back and forth, because it's more work to hire somebody. You have to train them. You have to supervise. You have to make sure they're doing. It's not like you just delegate and you don't ever look at anything. It generates a lot of work to supervise somebody. So it does take some things off your plate, but it adds other things. That's why I think I decided to not grow more, because it adds more administrative stuff that I don't want to do, doing their performance review or making sure that whatever compliance things for somebody else. I'm good with doing my compliance stuff, but to have to be like the HR things, having to, oh, they're sick. Now what do you do? Or now they're unhappy. How do you fix it? I don't know. I just don't. If you had asked me 10 years ago, I thought I would be like the CEO kind of person. And I'm not. I like to lead, but I like people to do their own thing. So in a way, I don't know. I just have changed my opinion about hiring staff many times. I've
Gotcha.
had some bad experiences too, where you hire somebody and the drama is you just get to work and stuck with the drama. And when you're employed, you don't deal with any of that, right? Somebody has some drama, you don't, oh, somebody didn't come to work, here's another MA. Or today you're going to run understaffed and you just deal with it. But having to actually be the person who fires somebody, oh, it's horrible. So I'm not cut for that. And I think one of the things that I like about DPC is I'm learning all these things that I thought I would like, that I don't like. Once I do them, I'm like, I don't think I want to do that again. As far as physicians, I have learned that I like to work by myself. I enjoy more being by myself. One thing that I have done, we didn't talk about this, but that I have done in the last, I would say, year or so, is that I expanded my clinic. So I had only one exam room, which is fine for me, and then the waiting area and a storage area. And the storage was my office. So then what I did is the space next to me became available. I'm in this building that's like a 3-story building that has, it's mostly lawyers and business people, like financial advisors. There's a couple of health related, like massage, other things, but mostly it's financial and lawyers. And the suite next to me came open. So I'm like, maybe I could do a little more space. My lease was up. And I was like, maybe it's time to grow the space. I don't know, maybe. So then I talked to my accountant, my lawyer, everybody, and see, is this a good idea, not a good idea? So it's good to have other people. So those are things I don't do myself. I have an accountant that does all the money things and the taxes. And I have a lawyer who I call and say, hey, what do you think about this, Kevin? Is this a good idea or not? They know me really well. So it's my team, but they're not physically in the office. That's my team, is people I can call and say, is this a good idea or not? So what I did is when I opened this extra space is here goes again, like that dream of what it looks like, that I don't know how it's going to be. It's starting to pan out and it's kind of fun, is to have space available, turnkey, for DPC doctors that want to start. So that, you know how scary it is to pay your own rent at the beginning, and it's so overwhelming to have all the OSHA, sharps, clear, all these things we talked about, insurance, internet, phones, everything you have to get your own office when you don't have patients yet. It's so scary because you're like, you see the bills coming in and you have 5 people, right? 10 people. It's nerve-wracking at the beginning. So one of the things I thought I would do, and this is just starting to come to fruition, is to have a space, a room that is turnkey for DPC docs, or docs that want to break free, but they're scared to do it on their own. And here's the space. You don't have to figure anything out. The sharps thing is taken care of. You come in, you see your patients, and you just pay an amount per day. At some point, you might have enough patients that this is not worth for you anymore. But then fly, right? Fly, little birdie. It's what I want. I don't want somebody to be with me all the time. I want somebody who then grows and gets their own space. Or maybe somebody wants to work part-time and they don't want to have an office and the hassle and the cost of an office, but they know that they're going to work maybe 1 day a week or 2. Maybe that's somebody that long-term can stay and work a day or 2 in my extra rooms. But I see it more as an incubator of baby DPC doctors, where they can, for a few months, rent from me. And then once they're ready and they have enough patients to get a place, then they can get a place. But it's not like it's not a thing that will stop them from jumping.
Mm-hmm. Absolutely.
Right?
And when you see commercial leases, typically 3 years, unless you can, negotiate that down, it's a pretty penny when you think about dollar per square foot, triple net lease, all of those things. And it totally adds up. So I love that you have this idea and this dream, and you've now expanded into another space to make that potentially happen for other people as this movement continues to grow, especially in Michigan. So that's awesome. Now, I want to ask this because being a solo doctor myself in DPC, how do you maintain boundaries with patients, especially if patients are messaging you multiple times a day, or if they are calling you after hours? How do you handle boundaries with your patients?
So I don't sugarcoat a lot of things. I am who I am. And that's one of the hard things about, if I don't like somebody, I can't hide it. I don't have a poker face. It's for good and bad. That's horrible. I just don't. So when I have an issue with a patient messaging me after hours, or it depends on the situation, right? Maybe it's that cow farmer and he works from 4 a.m. till whatever, and then he just wakes up at 5 p.m. So that to me doesn't bother me. So that doesn't bother me because I understand that situation. So that's when knowing your patients, that's the difference. Is if it's the person that's just sitting at home doing nothing and has had a cough for 3 weeks and they decide to text you on a Saturday, I'm like, okay, you know what? This is not appropriate. What I do is first I take a deep breath. And it's one of the benefits of text is that they don't get to see my face and my eye rolling. So when that happens, I just like deep breath. And I do not ever say anything on text like that I don't put boundaries on text because they could read it completely wrong, or an email. I would read things different, right? You read with your own tone. So I take care of them and they say, not a problem, let me take care of you. And I do whatever we need to take care of them in that moment. And then they get put on a list. So I have a little list of the people I need to talk to about boundaries in person. So the next time, so I don't bring them in for that. The next time I see them, then I talk about it. And they say, hey, you know what? And I always try to use humor because that helps. I've noticed that you always ask for your prescription on a weekend, or you always want your refill when I'm on vacation, even though I sent the email reminder. You always are the one person that texts me in the middle of my vacation. And I have no problem refilling it, but can you tell me why is this going on? And a lot of times they're like, oh, I'm sorry, doc, I didn't realize. Oh, I'm so sorry. And then they stop doing that. But I just tell them how I feel. And I said, you do realize that when you're texting me, you just broke my vacation, even though, and it's not an emergency. And I say, if you're sick, certainly it's appropriate. If you're not sick and you just forgot, it's like, you just wait until I come back. But some people get it and they understand and they're like, oh yeah, it's your time. Of course, it's you. They understand it's you answering the phone. So that has helped a lot, is I deal with it in person. There are people that just don't understand the difference between what's urgent and what's not. Mm-hmm. And they don't know what time of the day it is. I had one patient, a very difficult patient a few years ago, who honestly, we had the conversation and she would text me so much. And I would see her every 2 weeks. So it's not like somebody I wouldn't see months. We had scheduled appointment because of this anxiety, right? Of like, what's going to happen? What's going to happen? Can I reach you? Can I get an answer? We had this honest conversation. I said, this is not good. This is not going well. This relationship is both ways. And you're not understanding this. And so we had a heart to heart. And she said, I honestly don't know what's urgent and what's not. Everything for her is urgent. Everything in her mind is an emergency. So I said, how about we train you? Every time you contact me, I'll tell you that's an appropriate call or not. Mm-hmm. So I did that for, I swear it's like 9 months. It felt forever. Every time she would contact me. So she's one that would send me, can I get some physical therapy for my knee? And it would be Christmas morning. And you'd be like, this is not an appropriate call. I'll deal with this when I come back to the office. So by training this person, it actually ended up working. And she settled down and she understood the boundaries, but it took forever. So some people do take longer. There's certain things I just don't allow. Somebody yells at me or calls me something. It's like a no-brainer, right? I mean, it's out the door. And I've had people who do that. It's so horrible because I don't like aggression. I'm always very friendly with patients and I'm always joking around. So to me, somebody calling me something, it's like, or telling me that it's about the money, right? All you want is the membership. Yeah, you and I that's not working. And I do tell patients it's both ways. It's you being happy with me, but also me enjoying your company. Because if I dread seeing you, or if I see a text and I just roll my eyes 50 times, this is not a relationship. It's both ways. So I try to mend it and fix it. And if it gets fixed, I don't hold a grudge. I don't like, remember when last year you texted me on my vacation? I don't. That's like off my brain and done. So yeah, boundaries are hard because we usually in the employed world, and a lot of people in DPC too, have somebody else answering the calls or triaging. So then in a way, you don't deal with that. You remove yourself from that. And if somebody has a problem, you call the manager to deal with this person. I can't stand it. When it's CPC, it's you who has to fire a patient. It's you who has to put boundaries. So it's hard because we don't get taught to do that. And I don't think anybody can teach you. You have to learn to do it because it's a personality issue. Some things that might drive me nuts might not drive other people nuts. And we see it all the time on our Facebook conversations, especially in our women group.
DPC women, yeah.
It's priceless. Where some people are like, some things driving nuts, and I read it. I'm like, that doesn't sound bad at all.
Yeah.
But I bet you there's things I post that people would say, that's a big nothing. And so you can't be taught. You can't be warned. So it's good to know that you have to do this when you do DPC. So of all the rainbows and unicorns that we promise in DPC, it's good to know that there are some sides of it that is, oh my God, what do you mean I have to deal with this? I'm the one that has to like chase payments of failed charges. Which now that's what my nurse does. Can you just chase this? I don't like chasing money. So yeah, it's hard. And nobody can teach you. You have to learn on your own. And it doesn't matter how many times people tell you not to do certain things. We all have to go through the experience.
Yeah. There was I think it's a TikTok meme. People are using this quote that is talking about how practice does not equal perfection. Practice equals learning to improve in the future. And so this idea that you can't be taught what your own boundaries are, it's so true. And just having spoken with people for this podcast, having read posts on DPC docs, having spoken with people in person, it's definitely something where any information that you hear from people, it's like you take it in, you take what can help you in your practice, and then you put that out and you see if it works for you. And if it doesn't, you just pivot and try something else. But I will say that for me, I love that you're constantly just adjusting to your patients, and just this idea of some people don't know what's acute. I found that to be the case, especially when people are new to the practice. So like in my practice, I have an acute line for only members. And then I have my regular clinic line open for normal business hours, and people can leave messages after hours. But so I had a patient call both lines because this patient didn't know which one was appropriate. And so I love that, just educating them off the spot. Yeah, you did the right thing. You absolutely did the right thing. And I'm sure your patients have experienced this, is that they understand. And many people have talked about this before on the podcast, but they understand that, like she's not joking when she says that she's available and accessible. She's actually available and accessible. So I love how you talk about your boundaries in your clinic. Now I want to talk about your involvement in the medical society local to you as well as on the state level. You've highlighted how you've been able to have time to do stuff like talk at the legislative branch in Lansing. But in terms of your involvement in the Michigan State Medical Society, being on board there, as well as now president of the Kent County Medical Society, when you are talking amongst those organizations, have you been able to affect the perception of DPC just within your local and state communities? And if so, how?
Yeah, so when I joined the County Medical Society, they invited me to do a talk. So I actually did a presentation of what DPC is. And every time when you talk to other physicians, I think the majority of docs nowadays know the difference. When they don't, I correct them. And I just say, it's not concierge, it's DPC. And I think that they get that also from how we're feisty. And they start talking about stuff that is so boring, about coding and billing. And I'm like, oh, dear Lord, I'm glad I don't have to do any of that. And they still like, their eyes are open and they're like, what do you mean you don't have to do that? And what's great too is talking to residents. So one of the things that happened to me is the same place I quit and they hated me because I quit. You know how it is. You're either in or you're in and we love you, or you are out and you're our enemy, right? You can't be out there and we're friends. The funny thing is I got invited to talk to residents after I quit. I said, you do realize that I just had to quit working for you because I hate your hospital. Not personally, but the institution itself, right? The system. And no, that's fine. You do realize that I might say things that you might not like. No, that's okay. Okay. So every year I get invited to talk to residents and they love it. because I say things that other people don't dare say. And when I got invited to be on the board, I did tell one of the directors of the admin people, I say, sometimes I need to put you need to like kick me or under the table or something, because I might say things that I don't have much of a filter anymore. And that's, I think, a DPC thing, is we lose our filter. They love it. They love that I can say things that they don't dare say, or they can't because they're employed. So they can't go to an event with the medical society and complain about hospitals, because guess what? You're in the system, so you can't say those things, but I can. So I think they have, I don't think it's just me. There's more DPC docs now. So they're all like, oh, you're like that other doc in Detroit or on the other side or in Lansing. And I think it's becoming more a thing. Mm-hmm. And the more we talk to students and residents, they won't be blindsided. If I had known before I graduated about DPC, maybe I would have done things a little different. Maybe I still had to get a job because I had a visa, but maybe I would have planned sooner instead of burning out. It's not good to burn out. The recovery is horrible. Yeah, it takes you forever.
Yeah, and in some ways, the feelings never leave you.
You get the PTSD, right?
Yeah.
You do. I every time I have to go to the hospital for something, I get, oh my God, somebody's going to show up and say you have 3 patients waiting and you're already a half hour behind, and the computer's not working and all these things. But
yeah, absolutely. I laugh because that's my reaction to cope with that. But everything you say, I can relate to that. And I'm sure a lot of listeners can as well. Over your time learning about DPC, researching DPC, doing DPC, thriving at DPC, what are some of the best resources that you could recommend to others who are interested in DPC, no matter if they be a medical student or in residency or in fee-for-service?
I think it of course depends on everybody's journey. I think I was meant to do things the way I was meant to do them. I think I'm here because of the path I've done. It's not like you just wake up one day and it happens. I don't know that I would have done a lot different. Maybe, like I said, if I had known it earlier, but also you have to be open to hearing things. So maybe I wouldn't have even seen it. Somebody would have said DPC, I don't think I would have seen it because I didn't consider it. The same way that, when I was in residency and we do all these rotations, I think the first time I rotated in a private practice that was not owned by the hospital was in my 3rd year or end of my 2nd year. And I was like, oh, this exists. I had known from Mexico, obviously, that there's other ways to do medicine. And through my medical school rotations in the US, I'd seen lots of systems. I did tons of away rotations. But I didn't know that here in Grand Rapids, that was an option. I was like, oh, I thought you all had to be in that part of the hospital. And so that was eye-opening. But I don't know that I would have seen it. I think that it's one of those things that you have to go through the pain to open your eyes and look for something else. So resources, there's a lot now. There wasn't much 10 years ago or 5 years ago. I listened to every podcast I could get my hands on when I was thinking of jumping and trying to hear what other people were doing. Going to conferences for sure, because meeting the people who are doing DPC is the most important thing. Even when we've been, like you say, thriving, you're 5 years in, I feel like an oldie. I even get a lot of stuff from going to conferences because some people are doing things different. And not so much sitting in a lecture, but being outside the lecture and hearing, oh, you're doing what? Oh, how do you do that? Or you hired a mid-level. How do you do that? And how do you do the actual reality of having somebody in your practice, or you have another physician or another location, or all these things that we do. There's so many ways to do DPC. It's so rich when you actually talk to the people. So of course, reading all the books you can read by, Doc Grego and listen to all the podcasts, all this information that is now in paper, right? And sharing the company, how to approach big business. It's awesome that we have these books now. Julie also has a book. All these people that are dying to tell their stories. Amazing. It's so rich. So I would say just read everything you can read, listen to every podcast, get on the Facebook groups because you see all the questions. People ask the same thing over and over. So you can see that it's this churning machine of information. and meeting the people. So if there's conference, I just always go to the conferences, because then hopefully in person, because who wants to socialize on Zoom? I mean, the most important part of the conference is the social part. Is not, it's not the lecture, it's the people you meet. That's where you learn a lot of the stuff of how to do things. The very basic stuff, do a lecture with slides, but all these panels that we always have are very rich, because then people will tell you their story. And we all have different backgrounds and different stories. So I think that's what I would recommend. I wouldn't change a thing. I just wish I'd done it sooner, so I wouldn't have been so tired. But like I said, you have to hit bottom to be able to look at other things. If you're comfortable in your fee-for-service employed position, why would you change? Why would you get out of that? Sometimes we see it on the Facebook group, right? People describe their job, and it's like, then why are you trying to get out? It sounds perfect. You have enough control. You have good payment. You will have enough hours that you're off, and you have a good lifestyle. Why change? I mean, the DPC is not for everybody, right?
Yeah.
I mean, I love it, and we're all evangelizing, but in reality, you have to find what's good for you.
It goes back to, we love it because this is what fills our cup, but you're so right. And that doesn't mean it's a bad thing. It's like if a patient doesn't join your practice, that's not a bad thing. There's one more person in the world who knows about your practice and who could potentially tell somebody else about your practice. So it's the same thing. Even if they don't join the movement, they might know somebody who wants to join the movement, and potentially someone who will rent your space as you get it ready for a new DPC doctor.
The same way, I think when you seem desperate, so when people are starting, if you are talking to people trying to get them to join your practice, it shows. And so I learned it early on. I was like, I must be doing something wrong. And then I changed the spiel. I said, okay, this is what I do. And I wouldn't give business cards or anything. I just want you to hear it. And then somebody would say, I heard you speak on the radio. Oh, it's you. So then they recognize you. And then they're like, oh, I heard. Some people's like years later that they heard about you. And it's 3 years ago, I heard you at a conference. I'm like, oh my God, that took a little bit. It was when patients are ready. And sometimes it's when they need something, or they have an illness that they see the cracks in the system, that then they want to join. But the same way, I think, with any business you do, is you just do the best you can and let them come in. You don't sit and let them come in. You go out there, but you have to give the information first, because then people have to trust you, which takes some time to build up. So I do recommend people get involved in the community, because that's how people will know who you are. It's not just somebody they can find on the internet. They've heard about you. Word of mouth. We say in DPCs, how do you get to word of mouth? By word of mouth. It just happens. At some point you hit a critical point where all of a sudden people are just coming, and you're like, whoa. And that's how I don't advertise for at all. And my website says clearly, I'm not taking patients, and I still have people that all the time ask to be put on the waiting list, which is really nice to have, because if somebody quits, I can just replace them. If it's a family member, I'll make an exception. If somebody's like my whatever cousin, sister, sibling, whatever is sick, and they can't get in anywhere else, I do a favor, and it pays back in karma. Just get out there and pave the roads.
Thank you so much, Dr. Amat, for joining us today.
Thank you for inviting me.
Next week, look forward to hearing from Dr. Lindsay Fawcett of SLO Health Center in San Luis Obispo, California. If you've enjoyed the podcast and you haven't yet done so, subscribe today and share the episode with a physician you may know who needs to hear about DPC. Leave a 5-star review on Apple Podcasts and on Spotify now as well, as it helps others to find all these DPC stories. Lastly, be sure to follow us on social media. If you're wanting to continue learning more about DPC today, check out dpcnews.com. Until next week, this is Marielle Concepcion.